And this time we are lucky to have our respected uh, teacher, my own teacher, Professor Vishwajeet Singh sir, from Department of Urology, KGMU, Lucknow. Not only urology, he is also the acting head of the Department of Nephrology for the expertise in renal transplantation and allied sciences. And he is currently the secretary, honorary secretary of the urolithiasis section of the USI, and successfully conducted the urolithiasis part in Bhopal indoor USI program. And he is an alumni of SGPGI Lucknow. He is a versatile surgeon and teacher and expert in all type of surgery, be it uro-oncology, endourology, laparoscopy, and any type of open surgery. Sir has special interest in clinical research and publication. He has hundred of international and national publication in his name. So we are very glad to have sir today for our Bengal Society program. Thank you, sir, for giving us your opportunity from your valuable time.
Thank
So
you.
with this introduction, sir, you can share your screen for the presentation. And our topic today is the Vesicovaginal Fistula, which is very common at my teaching period during the KGMU period. In Kolkata also, vesicovaginal fistula is very common, not a rare disease, but the vesicovaginal fistula is evolving from normal delivery problem to the lower uterine cesarean section problem. So from the lower side, we are gradually going to the upper sides. So we will learn from the Vishwajeet sir what the current situation, what the ideal operation time, and what the principle, what is the best outcome, and everything. Before that, Mr. Sir, you can give some small introduction from the Bengal Society.
Yeah,
As secretary is not there.
Yeah, this innovative plan to have a UROCONNECT regularly is a very good effort from our society. Basically, to connect all luminaries and expert consultants from all over the countries to interact with the Bengal Urology Society members as well as with the students. And topic chosen today is a very relevant one. As Bimalesh was rightly pointing out, the spectrum of vesicovaginal fistulas has migrated from a delivery-related issue to a obstetrics-related issue to a gynecological surgery-related issues. And it's a very important in the sense when a consultant comes or refers a patient, there is a lot of angles, not only to treat the patient, but also to manage the legal aspect to save the consultants, because many times patients are ill-informed and they consider this to be a negligence of the surgeon rather than an inevitable complications that can happen once in a while. I always counsel them by saying that gynecologists are the surgeons who are playing with the fire, and sometimes they will burn their fingers. And this fire is the proximity, the anatomical proximity of the lower ureter and bladder with the genital organ of the females. So while they're operating, they're bound to injure it sometime or other. And you should not blame it on the surgeon, rather you should blame it on the anatomical proximity. I would rather say they have been very good at their job. That's why the incidence is so low. So I believe this topic need to be understood very well by all urologists, because they may be called in the theater, they may be seeing a patient in the post-op, and you have to be very careful, not only in doing the job properly, but also managing the legal and ethical aspects of it. I believe with this short introduction, I will request Dr. Vishwajeet to go ahead with his talk, and we will all listen, and I feel at the end of the lecture, we will be all wiser. Come on, Dr. Vishwajeet, the screen is yours now.
Thank you. Thank you, sir. Thank you, Dr. Mishra. Thank Bengal Urological Society for inviting me for this very prestigious talk. In fact, Dr. Bimalesh, whenever he was meeting, then we were discussing for this talk, and finally that day has come. And today is very auspicious day. I wish happy Ram Navami to all of you. Thank you. So in the beginning, I'll talk First, general things for the management of the Vesicovaginal Fistula, then some tips and tricks, and then we'll discuss one case of the congenital Vesicovaginal Fistula, the way I managed it. Next.
You can make it full screen, sir.
Yeah, just making it. Yes, you can see now. Yes.
Yeah, nice.
Is it visible?
Yes, sir. Yes, sir.
Yes, sir. So Vesicovaginal fistula is an abnormal communication between urinary bladder and vagina, either acquired or congenital with involuntary escape of urine. So coming to the etiology, so overall in the genitourinary fistula, the VVF accounts for 40 to 70% of the cases. And I have mentioned here about the urethrovaginal fistula, and vesicocervicovaginal fistula, because these three are usually associated. Sometimes they can be associated with the vesicovaginal fistula. Very rarely can be associated with the RVF, means rectovaginal fistula or anovaginal fistula. So coming to the etiology, the congenital, it's very rare, and acquired is nowadays the gynecological cause is more common now in compared to the obstetric cause. So India was traditionally being recognized as the obstetric cause was the leading cause, but slowly because of the better availability of the healthcare facility, the gynecologic fistula or surgical fistula are the leading cause of the fistula. Traumatic fistula happens in the pediatric age group. Malignant fistula sometimes in the cases of the CS cervix undergoing radiation, and malignant fistula can happen in the any pelvic malignancy and neglected cases, and some very rare inflammatory cause like the GU tuberculosis. Nowadays it's very rare. Lymphogranuloma venereum, not in our very common in our setup. Schistosomiasis in some other part of the world, actinomycosis, and inflammatory bowel disease. So these are the causes for the fistula. So coming to the diagnosis, with the advent of the CT scan, the diagnosis of fistula has become very easy, but one should remember the clinical history and pelvic examination and 3 swab tests for the post-graduation. So imaging, ultrasound of the kidney and ureter bladder should be done in all cases because easily available, and CT scan, as I said, because of this the fistula, complex fistula or difficult fistula can be diagnosed with easily. And MRI I have mentioned here, MRI, particularly if the fistula is associated with some Mullerian anomaly like the congenital vesicovaginal fistula. So MRI sometimes it is used to diagnose the disease, and cystoscopy in RGP is usually indicated for the diagnosis of the fistula. So coming to the symptoms of the VVF, urinary incontinence, vaginal leakage of urine may coexist with menuria. It can be the only presentation in the congenital vesicovaginal fistula. Recurrent urinary tract infection or foul-smelling urine are the can happen. Pelvic pain or discomfort can have the presentation. Fecal urea if associated with the rectovaginal fistula or enteric fistula, post-discharge or irritation of the perineum, but these are the less common presentation. Most of the time, the vaginal leakage of urine is the commonest presentation. You can see in this picture, I have taken the cystoscopy being diagnosed for the diagnosis of the fistula. So after doing the ultrasonography or basic investigation, blood chemistry, all these things, so then we go for the cystoscopy. You can see usually the fistula is single but can have multiple openings. In the second diagram, you can appreciate here, there are multiple fistula. So they should be diagnosed before in the evaluation of the patient. So there are approaches for the management of the fistula, like abdominal approach. Traditionally, it is being done open surgery, and all are familiar with the UROCONNECT technique. So with the time, there was some modification of the UROCONNECT technique. So that is the modified UROCONNECT technique. This was primarily reported from our center here in the KGMU Lucknow. So today is the era of minimally invasive surgery. Laparoscopic VVF repair is becoming slowly more popular in compared to the open surgery, but open surgery is definitely has a place for the complex cases. Nowadays, there is focus on the robotic repair of the VVF. And most of the cases of the vesicovaginal fistula, near more than 90% cases can be managed by the transvaginal technique that is called the transvaginal repair. So coming to the trans-abdominal repair of the VVF, After doing the basic workup, so who are the patients for the trans-abdominal repair? So supratrigeminal fistula with incapacious vagina, narrow vagina. So that is an indication, particularly for the beginners. If it is associated with the tear of the cervix, that fistula has extended to the anterior fornix, that is called the cervico-vaginal fistula. Large fistula with reduced bladder capacity, which might need the augmentation cystoplasty. Multiple fistulae associated with distal ureteric stricture or ureterovaginal fistula. Ureteric orifice at the margin of the fistula. VVF with associated pelvic pathology, like the patient has completed the family and they want for the hysterectomy to be done, or may have associated pelvic tumor or fibroid. In those situations, transabdominal approach is indicated, or when the VVF with associated high RVF. So these are the indications for the transabdominal. So doing the workup of the patient, we have to pick up these conditions. So they are the indication for the transabdominal repair. So coming for the transvaginal repair of VVF and ureterovaginal fistula, because both are done by the transvaginal route. So that is complex. Many times we ask to the residents, what is complex fistula and what is complicated fistula. So I'll say the complex fistula if it is more than 4 centimeter, and simple fistula if it is less than 4 centimeter, regarding the size of the fistula. And if it is associated with involuntary involvement of the continence mechanism, like the reduced bladder capacity or reduced bladder capacity, partial loss of urethra, scarring of the trigone and vesico-urethral junction, multiple openings, multiple fistula, vesico-cervico-vaginal fistula, previous failed repair. So these are the examples for the complex fistula. So complicated fistula, one step more. They are one stage more. Suppose complex fistula associated with the, if the size is more than 6 centimeter, additionally, there is a complete loss of urethra, severe scarring of the bladder, associated rectovaginal fistula, high RVF, ureteric orifices at the margin, so requiring ureteric reimplantation, a small bladder with bladder calculi, and radiation fistula. So radiation fistula comes technically under the complicated fistula. So transvaginal repair of vesicovaginal fistula and ureterovaginal fistula, it is one of the most commonly performed technique even by the urologists nowadays. Traditionally, there was a belief that the gynecologists are more familiar for the transvaginal repair, but that theory doesn't no more exist today. Even the urologists are doing more and more fistula by the transvaginal route. And I said in the beginning, more than 90% of the fistula can be dealt by the transvaginal route. And for that, adequate vaginal lumen is a prerequisite. And simple VVF, I said, for less than 4 centimeter. Complex VVF 4 to 6 centimeter, and complicated VVF is more than 6 centimeter. All can be repaired by the transvaginal route with good results. Interposition flap is not always required, as in particularly in the simple fistula while doing the fistula repair. So overall, I said in the beginning that 90% can be done by the transvaginal repair. So now there is a focus on the laparoscopic repair, and particularly in the youngsters, because laparoscopic surgery is very popular today. So laparoscopic repair, of course, it is minimally invasive. So there is a reduced morbidity and less hospital stay. So VVF, single or multiple VVF, and if they are adjacent, and if it is particularly supratrigeminal VVF, they should be taken for the laparoscopic repair. Less than 2.5 centimeter at our center, I have checked the literature also. Generally, they take less than 2.5 centimeter for the, if it is single, or if it two fistula lying side by side, as in this diagram, you can see here, there are two fistula lying side by side. So both can be taken in the single fistula. And interposition flap, either in the form of omentum or tinea epiploic, they are generally interposed and have excellent outcome. More than 95% success rate have been reported in various studies. So now coming for the tips and tricks which Bimalesh has requested me for the VVF repair. The key principle of fistula repair relies on the optimum timing and the preparation of the patient. Ideal positioning, exposure and access, broad tissue mobilization, tension-free closure, watertight closure, suture technique and multi-layered closure, use of optimum suture material, interposition flaps, autologous versus synthetic. There nowadays many emphasis on many of the papers coming for the synthetic interposition. Catheter management is also very important because these patients have the multiple tubes. So we have to very careful for the catheter management, post-op catheter management of bladder and bowel, and management of the post-operative leaks. So our tip-centric revolves around all these points. So coming one by one. Related to the optimum timing and the preparation. There are two school of thoughts for the timing related to the fistula repair. Early repair has and delayed repair. Early repair has advantage. It is less psychological morbidity. It produces less psychological and social morbidity of the urinary incontinence to the patients. However, the success of repair depends on the urinary infection, extent of ischemic injury, surrounding edema, and hematoma. Many authors have reported the discouraging results, so it is less popular, particularly in our country. And delayed repair, it is done 3 to 6 months after injury. There is a particular subset of the patient, that is radiation fistula. In radiation fistula, usually we have to wait for 18 months till the last dose of the radiotherapy and chemotherapy is completed, because the tumor cells may remain viable till 1.5 years. So before going for the radiation fistula closure, we may have to go for the biopsy from the margin of the fistula. The advantage of delayed repair, lack of local tissue edema and hematoma with resolved infections. So success rate is said to be the more, and it is more popular across all over the world. So at our preferences, delayed repair, most of the patients are referred cases, and some authors have shown discouraging results of early repair, I said in the beginning. So treatment of bladder stone, and if the fistula, sometimes the fistula can be associated with the bladder stone. And these patients are many times anemic also, hypoproteinemia, poor nutritional states, skin excoriation around the perineum, worm infestation, and urinary tract infections also. So going for the delayed repair, we have time for treating these all associated morbidity and factors. So now coming to the ideal positioning what should be our approach for the repair of the fistula. For the abdominal repair by open or laparoscopic or robotic, supine position with or without head down or head up position depends upon the choice of the surgeon. For the transvaginal repair, exaggerated lithotomy position with vaginal retractors, various kind of retractors are available. The cold adrenaline solution helps with the hemostasis and dissection planes. I have seen in some of the workshop, particularly in the South India, many surgeons are taking the help of the this diluted solution of adrenaline, but our preferences, we don't use it. So modified jackknife position, or that is called the reverse lithotomy position. This is our preference. Bimalesh is trained from Dr. Bimalesh is trained from our center, and he knows our preferences. This doesn't allow strain to the neck in prolonged surgery. So surgeon has to see in front. Rather in the exaggerated lithotomy position, the neck remains a long time, is elevated. So that gives a strain to the neck, and that is very uncomfortable for many of the surgeons. So this is a modified jackknife position, or that is called the reverse lithotomy position, and the fistula lies in front. So that helps makes you comfortable. Now coming for the exposure and access to the fistula. Access to the fistula by transabdominal route, depending on the indication, must be decided based on the clinical examination and the imaging. So open transabdominal repair either by suprapubic midline or phalangeal incision. The suitable retractors and stitch sutures must be taken for the good fistula exposure. Ureteric orifices must be cannulated with the 6 French, 5 French ureteric catheters to prevent the accidental ureteric injury. For the laparoscopic repair, the camera and other port placement must be done with the planning to ensure good laparoscopic repair. And for the robotic repair also, that needs good planning and training. So these are the some of the point to be noted for going before the transabdominal repair of the fistula. So coming for the exposure and access of the fistula, for the transvaginal repair, vaginal retractors and stitch sutures are needed for exposure and visualization. The ureteric catheters must be placed before taking for the repair if ureteric orifices are near to the fistula margin. A Foley catheter inserted in the fistula with inflated balloon needed to give tractions to expose and bring fistula for the good dissection. You can see here in this diagram, this Foley catheter has been inserted and given traction. So we put a ureteric catheter also, so that helps in insertion of the Foley catheter, or because sometimes the Foley catheter can get ruptured while taking the suture. So in those situations, we have control by placing a simultaneous ureteric catheter also. So these are the some of the tips for good dissection and traction for going for the fistula repair. You can see in this diagram, we have done here in many of the pediatric VVF repair. So this patient had a traumatic vesicovaginal fistula, and we did the transvaginal repair with a small retractors because the vagina is not very capacious, and we have taken the small Marcius flap also, and the patient had a complete cure of urinary incontinence. So coming for the broad tissue mobilization, the margins must be mobilized for not less than 2 to 3 centimeters from the margin of the fistula. Many times, particularly the young surgeons, they are little scared or afraid of going for the good mobilization. So the first chance is the golden chance. So we should not compromise on the mobilization of the flap. We should have a good plane between the bladder and the vaginal wall. If there is tension on the suture line, the full thickness lateral vaginal wall relaxing incision must be given to avoid any tension on the suture line. So this step, this is not for beginners. This step one should call the seniors, because they have experience how to give the lateral incision and how to have the less tension on the suture lines. Minimal monopolar cautery we use to avoid ischemic tissue damage. In my practice, I don't use monopolar cautery. Whenever it is needed, the bipolar cautery must be used. And in transvaginal repair, my preference is to avoid the monopolar cautery. In fistula dissection, in harvesting Marcius flap, the bleeders at the bed can be cauterized by monopolar cautery. So most of the time, one should try to do the cold dissection. So to avoid the tissue ischemia, but even if it is required, one should go for the bipolar. So these are the small steps. If collectively they give, if all have been applied, then gives the good result. So tension-free closure is very important. The suture line should not have tension. If there is tension, we already said that lateral relaxing incision must be exercised. So there is an important aspect about when we give the circumferential incision across around the fistula. So many of the surgeons, they say that they excise the margin of the fistula. But in our practice, at our place, we don't excise the margin. We trim the margins, but we deliberately preserve the margin, because this is a comparatively tough tissue. So while taking the knot, so they hold the knot, there is a less chance to for the tear and give way for the surgical sutures. So you can see in this diagram, so this is diagram, there are two fistulae lying side by side here. You can see here. So both have been taken in the same circumferential incision. The margins were further trimmed, and that closed as a single suture line, and took a Marcius flap for a very beautiful closure, and the patient become completely cured of the urinary incontinence. So watertight closure, many surgeons are doing after end of the procedure, either transvaginal or transabdominal. They distend the bladder by 300 to 400 ml of the normal saline with some betadine or methylene blue to check the apparent leaks. At the apparent leaks are noted, one should take the additional interrupted suture at those points. But my preference at our center, usually we don't do. But yes, in the beginning, I saw many of my seniors, they were doing. So I learned from them. And slowly, one become very confident, and they know that these steps can be escaped. So single layer or multiple layer, so that is also a important issue. Many times single layer, many times multiple layer. So usually these depends upon the nature of the local tissue. If it is a very supple and robust tissue, so one can go for the 3 layers closure. Means the closure of the vaginal wall, then the perivagal or the soft tissue, and then the vaginal wall, the bladder and vaginal wall in between the soft tissue. But if the the tissues are not very supple or not very robust or not very healthy, in those situations, better to take the 2 layers and put a interposition flap, whatever, local Marcius flap or omentum, whatever. And the choice of the suture, that polygalactin 3040 sutures are preferred. Sometimes 20 sutures needed for the vaginal wall closure. And for the vaginal wall closure, it should be by interrupted, either in the transvaginal or transabdominal repair. And the bladder wall closure is in the transabdominal repair. It is my preference is for the continuous 30 closure. Or sometimes their additional sutures may be taken at where someone is not very satisfied about the continuity or flow of the knots. In transvaginal repair, again, I said the vaginal layer interrupted 30 and bladder wall by 2030, single layer interrupted or continuous. So that depends upon the choice of the surgeon and experience of the surgeon. So finally, we coming for the interposition flap. So interposition flap traditionally is the advocated. Routinely it was advocated, but recently there are emphasis on omitting this interposition flap because of the morbidity, which was never inquired from the patient. Now the patients are more and more the things that social stigma and talking to the patient, counseling that is becoming better. So now the patients are coming with the complaint that they have a local side morbidity. So can we have patients in whom this interposition flap, particularly in the vaginal repair, can be omitted? So they say that simple fistula, if it is less than 4 centimeter, one can escape the Marcius flap, rather go for some synthetic material interposition in the form of the Surgicel or gel foam or fibrin glue. So they are being slowly being used, and now the papers are coming and they have shown very good encouraging results. So advantage of the interposition flaps are that increase the success rate of repair. But the disadvantage, I say, I already said, the local morbidity. In transabdominal repair, omentum and tinea impupuloic, peritoneal flap or transverse abdominis muscle flap. So they are the usual interposition flap. In transvaginal repair, Marcius flap, gracilis muscle flap, peritoneal flap, omentum, they are generally used. In the transvaginal repair, I have observed in some of the patients, they have very thin vaginal wall, particularly in those patients who have hysterectomy at some point of the time. So at that point, sometimes the vaginal vault getting open, and you can see the omentum is descending. So that omentum can be used for the interposition in transvaginal repair also. The vascularized flap prevents suture line opposition, absorbs lymphatics, reduce dead space, and bring hemostasis also. These are some of the pictures of the, this is the omentum, here the Marcius flap, and here the oxidized cellulose, that is we call the Surgicel. So we had a randomized study whether the interposition is always needed. So it was a part of thesis. We had allotted a thesis to our postgraduate students. He performed randomization in 2 arms, transvaginal and transabdominal, and with interposition, without interposition in the both sides. And finally, 126 patients were randomized. And what we observed, we had very wonderful observation. These all were the simple fistula, less than 4 centimeter. And that was published in the Turkish Journal of Urology. And our conclusion was The success rate are similar for repair of simple vesicovaginal fistula with less than 4 centimeter, irrespective of use of interposition flap, whether use or not use. But recently we have started using the synthetic material because that saves times also. And the overall morbidity following repair with interposition flap are higher when compared with the repair without interposition flap, either by transvaginal or transabdominal route. Means routine interposition is not needed in simple VVF. So let's come for the catheter management. So these are I'm taking these points. Usually we don't discuss much about the catheter management. So because the patient has to be on the post-operatively for long time, 3 to 4 weeks time, on the multiple catheter, suprapubic catheter, periurethral catheter, for 2 weeks. If it is a transabdominal, we usually put the ureteric splints in the form of the feeding tubes, one abdominal drain for 48 hours. And in the transvaginal also, the ureteric orifices at the margin, then we put the ureteric catheters also. So patient should be counseled and they should be ready also for taking care of the multiple tubes. It has happened that the patients were not very much explained about the multiple tubes, and they were very upset in the post-operative period. Okay, I have to bear so many tubes. So good preoperative counseling, it is not less than a trick, a good trick for managing post-operative, managing the patients. And post-operative, usually we keep the catheter for 3 to 4 weeks, and then we give the widening trials. Let's discuss some thing about the management of the bladder and the bowel. So uninterrupted continuous catheter drainage must be ensured, and our preferences are both SPC and PUC. So anticholinergics, usually dual mirabegron or sulfenacin, must be given if there is a post-operative spasm. And now it has become very routine kind because we usually give from day 1 week. And if the immediate post-operative period, we should give the intravenous buscopan. Mild hematuria can happen to any patient, so that usually it disappears with the good hydration and counseling. Constipation care, pain and pelvic discomfort, that has to be also counseled before going for the repair. Vaginal packs, they should be removed 24 to 48 hours. And many people do the routine vaginal dosing, but vaginal dosing is not always done at our places. Usually we don't do it because many times it is done by the paramedical nursing staffs on duty, and they have sometimes have done the injury to the vaginal wall. So either do by the very trained personnel or the resident doctors on duty, or it is better to escape. Generally keep the good hygiene of the perineum. That only is required. Temporary paralytic ileus sometimes persist, and particularly in the transabdominal repair. So that has to be taken care. Management of the post-operative leak. This point is very important. I have brought a very important point here. The immediate post-operative period, there can be some leak. So what are the causes? Rule out the catheter block and the kinking. Rule out the bladder spasm. Change of the urethral catheter with larger size if it is not well draining. So we take usually good quality catheter, but many times it is not available. And if we have ruled out all these 3 factors, then go for the looking at the imaging, whether was there any other small associated fistula that has left during the repair, because VVF can have the one large VVF can have other small undiagnosed VVF. That is a cause of immediate post-operative leak. Delayed leaks happen in the form usually technical failure and ischemia to the tissue. So we have to check the patency of the catheters, and if needed, change the Foley catheter with larger size, particularly the periurethral catheter. Our practice is put to both the SPC and the PUC both. So at the 3 to 4 weeks, we go for the cystogram contrast study. And if the contrast, there is evidence of contrast extravasation, usually we keep 1 to 2 weeks more the catheter in place, and then we give the widening trial. But it can happen that the following catheter, the contrast study was the normal, but even then the following catheter removal, the patient leaks. So that in those situations, we again have to recatheterize the patient and keep on the supporting medicines. We also have seen that the voiding trial was very successful. Patient was very dry, and they went to the home and came after 1 to 2 weeks with the leaks, and they were very significant leaks. So we have to instruct to the patient. They have to be 3 months separate from their spouse also. So that point is also very important. Probably they had some point of time they had early contact, and that led to the leakage of the fistula. So I have one case of congenital vesicovaginal fistula. This patient is very interesting. So a 16-year unmarried female presented with recurrent suprapubic dull aching pain with cyclical hematuria for 3 years. The ultrasonography, abdomen and pelvis showed the normal Mullerian structures, and the physical examination you can see here, there was no vagina. There was complete agenesis of the vagina. So this was the cystoscopy picture before menstruation. You can see here in this diagram there was here the cystoscopy during the menstruation. That shows this is the characteristic of the menstrual blood, and that shows the clot and bright red color blood. Both are coming from that orifice. So this was the characteristic of the congenital vaginal fistula. It can happen sometimes, very rare. We had for the last 21 years, I saw one case of the congenital vesicovaginal fistula. So cystoscopy before menstruation and cystoscopy during menstruation can give you an idea what is the cause of the menorrhagia. So this patient was furthermore investigated. Further investigated, and for the Mullerian anomalies, we should have the MRIs. We can see here in this diagram. Here is the uterus, and this was not here. The planes and the things are not very, because of the vaginal agenesis. This was completely obliterated, and here in the perineum. So this was about 8 centimeter distance, but not very clear. So we got the CT scan of this patient done, and you can see the CT scan. This is uterus. And this is coming on the posterior wall here. This coming on the posterior wall. This is Foley catheter. So this was again about 8 centimeters. So we did the diagnostic laparoscopy of this patient. So that shows the very good uterus, fallopian tubes bilaterally, and ovaries. The ovary was little bulky, and this is the cervical end. And anterior, you can see the bladder is seen. So we decided to go for the sigmoid vaginoplasty and laparotomy. So our aim was to disconnect the fistulous tract from the bladder, the closure of the posterior bladder wall opening, creation of a neovagina using the sigmoid colon. So here you can see through lower midline incision we entered, and this connection was fistulous connection was divided from the bladder. The posterior bladder wall is being closed in 2 layers. We took a 10 centimeter of the sigmoid colon based on the sigmoidal arteries, and the colocolostomy was performed, and then we after doing the colocolostomy, the isolated segment was closed at the upper end, and the lower end was brought at the mucocutaneous junction in the perineum. So this is the immediate post-operative picture. So this was the sigmoid vaginoplasty. You can see the pre-operative picture, immediate post-operative picture, and this is picture at the 3 months of the follow-up. So we did the vaginoscopy in the follow-up at 3 months. So this is the sigmoid vagina before menstruation. And we also have the picture during the menstruation. This vaginal, that shows that this conduit between the cervix of the native uterus and the vaginal opening is patent. So that was the characteristic, and this patient was kept in the follow-up for for the 3-4 years, she was not conceiving. So she came to us whether and then we had a question that whether the sigmoid mucus was a deleterious effect on the sperm, and we asked to so many experts that is it spermicidal? But then this lady came with the pregnancy and the baby delivered by the LSCS. So we got an answer that the cervical, this sigmoid mucus is not deleterious for the sperm. So this is all about my presentation. I try to make it short. Thank you for the patientful listening. Thank you all. Thank you.
Thank
And
you,
this,
sir. There
and
are
this
two
published
questions, sir.
also. Yeah.
Yeah. So I will take the first question from Professor Sunirmal Chaudhary.
Yes, sir.
Tell us some tricks of how to operate higher fistula transvaginally.
Yes, transvaginal, I said we had our preferences for doing the transvaginal repair. So we take advantage of the position. So that helps. So position, it's individual choice. So the first we do the catheterization of the fistula tract. We put a electric catheter in the fistula, and then you put the patient in the position, and then you give traction to the fistula, and then you put a Foley catheter of suitable size, usually 12 French or 14 French, sometimes 10 French also. So because in a small fistula, and after inflating the balloon, you give traction. You give traction to the balloon. So fistula comes on very your field of vision. It becomes comparatively lower. By doing these maneuvers, and we should have good retraction also, vaginal retractors also. By doing these maneuvers, the high fistula is usually managed by the transvaginal route. As I said in the beginning, the prerequisite is to have the capacious vagina.
Okay, sir. Thank you. There is a question which is not VVF but a ureterovaginal fistula.
Okay.
Regarding from Dr. Satra, regarding case of ureterovaginal fistula, we had placed a digest stent for 2 months.
Yes.
After stent removal, the patient has again developed leakage.
Yes.
RGP retrograde pyelogram has been done and appears normal. Kindly guide regarding the next step in management. So it's basically ureterovaginal fistula, sir.
Ureterovaginal fistula. So the fistula is usually we keep the stent for 2 to 3 months, but it has been seen sometimes that after keeping the stent for even the 2 to 3 months, and if in the RGP and imaging study, if you are sure that it is ureterovaginal fistula, it is better to put the one more time the stent, and then you take out the stent after 3 months. If even after when there is a leakage, it means the margin has epithelialized. So better to go for the uretic reimplantation in those situations.
Sir, what is your opinion regarding double stenting in this scenario, ureteral fistula? It is recommended, or there may be some
putting two
double
stents.
stenting, two stent.
One in a uretic orifice, you put 2 stent for what?
Yes,
For better drainage.
yeah,
For better drainage.
Is it
There is no single way to manage, because one has to learn from his own experience then how to increase the success rate of in any of the complication or any of the scenario. So he might have exercised putting the 2 stents, and the results could have been wonderful. So I'll say, if that has shown the good result, you should go with your technique. I'll suggest it. Yeah.
Thank you, sir. And last question from our president, Dr. Misra. What is the timing of VVF in your practice? I think you have already told, sir.
Yeah, VVF.
Timing of VVF.
Timing up, as I said, we have the referral center, and we are getting patients in the Uttar Pradesh, whole of the Uttar Pradesh, and it's a very big state, very dense population. We get patients from the nearby districts of the Bihar also, nearby district of the Madhya Pradesh, and many patients from the Nepal also. So at our institute, because most of the services are free, Dr. Bimalesh, here many the cases can be done without even then government is also with the so many schemes. So the finance is not an issue at our places. So always we have VVF in the line. And we have done many of the studies, and recently we have reported the 25-year experience of Vesicovaginal genital fistula. 638 cases we have reported. So, so by the time patient comes to us, they become usually late. And our preferences is also going for the late repair back, because that has shown worldwide, undoubtedly that has shown the good result, going for the late repair of the genitourinary fistula, including the vesicovaginal fistula. Yes.
I can remember one patient in KGMU for 20 years, a patient
Yes.
from Nepal, 20 years
Yeah,
having
20
VVF.
years. And
Yes.
that is so living in the silence, and they live
Yes.
very. I recently had a patient. That patient has very long neglected fistula. She came with the family, and she was earning making money for the fistula repair for last 1 year. I was very upset to know that you are for the so many years you have VVF. And who told that patient that you have to arrange some money for very small amount she was earning and earning. And then suddenly one day she come to me. Immediately we admitted and we operated those patients. So they are the real sufferer. And so many times I say to the residents in the examination, what you can do for these patients. So this is very important question. What you can do for these patients. So I got the answer from some of the residents. Sir, I'm a resident. What I can do for her? Whatever you will say that I'll do it. Then I say no. This because they need some very sympathetic talking. So that you can do. You talk very sympathetically to these patients. Second, you ask your faculty or to me that sir, this patient is VVF. So I want to give her priority in the OT list. Then I have no objection. Then there are so many government schemes. If they don't have finances, you ask me, or you can talk them that you can get benefited by these schemes. Counseling, making their papers, sending those for the superintendent authorities. And get their consumables intent at the earliest. So these were the small things we can contribute. If we in the system, if anybody can contribute for these very unfortunate patients.
Yes, sir. Sir, one last question. How do you place the synthetic material? Do you use
Yeah.
glue or suture to keep the
Yes,
synthetic material in
synthetic
place
material.
from the plaster?
Dr. Sunirmal Chaudhary Sarij here. I saw his one paper he has presented on the fibrin glue. So that glue, sir, know how it, but that you have to make solution. But the very easy oxidized cellulose, that is we say Surgicel. Left and right we use in the making the fistulage. So Surgicel, gel foam, and these are the things you can use for the interposition. Fibrin glue is comparatively expensive, but we have used it. So they need not very special preparation, and available at very low cost. And the most important is that the dissection is not very much needed. Just you dissect 2 to 3 centimeter from the margin of the fistula, and it is time. So harvesting a Marcius graft is not in easy. That it takes time. You have to be very meticulous. And particularly those who have received the radiotherapy, radiation fistula, so they have edema in the pelvis and the genital regions. There are so many. For prolonged, they have a serious secretion, seroma, and sometimes skin gap also. And many times we don't talk to these ladies. Many times they say that when we talk, we ask some lady residents at our center. We had a lady resident. We had allotted a quality of life paper on the VVF. And she was talking to the patient, and they're getting opened, and they had lot of issues related to their sexuality, dyspareunia, altered sensorium at the labia. And there are so many issues which usually we don't take in account. So there are so many parameters assessing the quality of life. So Marcius flap definitely has a morbidity. So whom to offer Marcius, whom not to offer. So less than 4 centimeter fistula, single fistula, first time undergoing operation. Gynecologic fistula, obstetric fistula usually complicated. They have a lot of ischemia. So these are the cases, and the experience of a surgeon is very important. How much he has time and how much he is dedicated. So these are the indication for going for the synthetic interposition. Yeah.
Okay, sir. Thank you. Thank you very much, sir. If there are no question.
Hello.
Yes, sir.
Hello, Bimalesh. Hello,
Yes, sir.
sir.
Go ahead.
Can you hear me?
Yes,
Yes,
I can
yes,
hear you. I can hear you. Yes, sir. I can
Okay,
hear.
sir. So we
Dr.
are
Somo
really
Mandal, our
honored to have
secretary,
you in
sir.
our program.
I can hear.
We are really honored to have you in our program, sir. This program is our child, and we are nurturing it like a small child. And we are hoping that this program ends properly with the legends and qualified professors and experienced persons like you can only help us grow. We are really happy that recently not only students but the professors are also joining us. And sir, and as you have already told, treating a BBF is not only treating the disease but also taking care of our life only, and that's very much
Yes.
true. And as a result,
Yes.
this
Yes.
subject is very much important. And we are really happy you have this explained to us so carefully and so beautifully. Sir, we'd like to have you in our newer programs also.
Okay. Sure, sir. Sure, sir. Sure. I usually for me, Kolkata is like my second home.
Thank you, sir.
I belong from the Bihar. Originally belong from the Bihar. So in the Bhagalpur, and in
Yes,
my childhood, I have seen so many times for examination and for this that Durga Puja, visiting to Kolkata. Whenever I go Kolkata, I really enjoy it. I like to talk to the people of Kolkata, and we like to go there, like to give talk. And today I am also very happy. Thank you, Bimalesh. Thank you.
Thank you. Thank you very much, sir. Thank you.
Thank you.
So, Mishra, sir, we can conclude the session.
Yeah, I believe it was a nice, enriching session rather. We learned a lot of points. I thank everybody, thank the participants, and thank Bimalesh nicely conducted it. And we look forward to put this such interactions in future in large number. So
Yes.
thank you,
Thank you,
everybody.
sir. Thank you.
Thank
Good
you.
night, sir.
Thank
Good
you,
night.
sir. Thank you so much. Thank you.
Good night.
Thank you. Good night, sir. Thank you.